Dear student, I am Dr. Prakash Mungli, a professor of biochemistry. So in this lipoprotein metabolism lecture, I am going to explain you metabolism of chylomicrons and VLDL, and also I will be going over applied clinical aspects related with the metabolism of chylomicrons and VLDL. Now let's get into the details. First, let's look at metabolism of chylomicrons. As you know from my previous lecture in the introduction of lipoproteins lecture, chylomicrons are synthesized from in the intestine. In order to synthesize chylomicrons in the intestine, we need Apo B-48. And now this Apo B-48, it is synthesized by a concept called as mRNA editing, because like any proteins, the synthesis of a protein molecule that needs a specific gene which is coding for a specific mRNA, and specific mRNA will undergo translation to make a specific protein. So here for Apo B-48 protein, a gene for Apo B-48 protein is not a Apo B-48 gene, it is something else. And what is that? So the gene that is coding for Apo B-48 protein is Apo B-100 gene. This is something interesting here. So Apo B-100 gene, which is there in the intestine being expressed, and after the expression of Apo B-100 gene, we are going to get Apo B-100 mRNA. And now this Apo B-100 mRNA, as the name says here, should give Apo B-100 protein, but that doesn't happen that way, because Apo B-100 mRNA will undergo something called as mRNA editing. You need to understand the concept here. What is mRNA editing? So mRNA editing, it indicates Apo B-100 mRNA. I am going to write that here. So mRNA having AUG as the initiator codon, and then at 48% of this 48% of Apo B-100 mRNA, there will be a codon called CAA, and this CAA, it is coding for glutamine normally. Okay, so this, after that it will go on all the way, and then there will be a stop codon, say it is UAA, UGA, UAG, so I'll write it as UGA, that's a stop codon, right? So that means entirely if all this is transcribed, so it will become Apo B-100. That's what is the expectation, because Apo B-100 gene has given Apo B-100 mRNA, and if this entire thing undergoes translation, then we get Apo B-100 protein. But in the intestine, it doesn't happen like that. So that's where comes mRNA editing. Now what is that mRNA editing here? So we have this Apo B-100 mRNA that came from Apo B-100 gene, and now that Apo B-100 mRNA will undergo mRNA editing. So in this mRNA editing, so in the intestine we have an enzyme called cytidine deaminase. Cytidine deaminase enzyme is expressed only in the intestine, and this cytidine deaminase enzyme, what it does, it is going to convert that cytidine, which is there at 48% of this Apo B-100 mRNA, where cytidine is there. So CAA is cytidine, which I told you is coding for glutamine, right? So cytidine deaminase enzyme is going to convert cytidine into uracil. Now the cytidine will be converted into uracil. That means there will be formation of UAA. CAA is converted into UAA. Basically C is converted to U here. That's the only difference, because cytidine deaminase is going to deaminate cytidine into uracil. Now UAA, instead of coding for glutamine, it's a stop codon. It is a stop codon. UAA is the stop codon now. So normally CAA was coding for glutamine in Apo B-100 mRNA gene. Now in the intestine, this mRNA editing is going on. This is mRNA editing here, where cytidine deaminase is converting CAA into UAA, and UA is the stop codon, which is appearing at 48% of Apo B-100 mRNA. So protein is synthesis will go on only up to 48%. Okay, 3' amino terminus, carboxy terminus, and the protein is Apo B-48 protein. And this is how Apo B-48 is synthesized here in the intestine, and this Apo B-48 is used in the synthesis of chylomicron, and that's what is mRNA editing that you must understand. So chylomicrons are synthesized in the intestine by using Apo B-48 protein, which is synthesized by mRNA editing in the intestine. So once we have Apo B-48 here, so this Apo B-48 is used to load all the lipids that are absorbed from the diet. You know, from the diet we absorb triacylglycerol, cholesterol ester, phospholipid in their simpler form, and once they get into the intestine, so these lipids which are entering as simpler form like fatty acid, glycerol, 2-monosylglycerol, cholesterol, lysophospholipid, all these things will undergo esterification process in the smooth endoplasmic reticulum. So lipids are there in the smooth endoplasmic reticulum. After esterification, lipid esterification is going on in the smooth endoplasmic reticulum, and Apo B-48, which is synthesized by mRNA editing, is there in rough endoplasmic reticulum. Apo B-48 is there in the rough endoplasmic reticulum. So lipids are there in the, see, this is a dietary lipids. Dietary lipids are there in the smooth endoplasmic reticulum. Apo B-48 is there in the rough endoplasmic reticulum. Now lipids from smooth endoplasmic reticulum need to be transported to a protein which is present in the rough endoplasmic reticulum. Okay, how that is done? So there must be a connection between smooth ER and rough ER, so that lipids from smooth ER can be transported to the apolipoprotein B-48 that is present in the rough ER. How to do that? So the connection or the link between these two is MTP, microsomal triacylglycerol transfer protein. So this microsomal triacylglycerol transfer protein, what it does, it is going to transfer the lipids present in the smooth ER all the way to the rough ER where Apo B-48 is present. So it's going to load all the lipids over Apo B-48. So that's how the transfer is done. So now I am going to take this out. So it is transferred. Now lipid is transferred from smooth ER all the way to the rough ER Apo B-48. Now you have Apo B-48 which is there in the rough ER, and that Apo B-48 now is with the all the lipids that are loaded onto it along with vitamin A, D, E, K. They are also there. So vitamin A, D, K, triacylglycerol, phospholipids, cholesterol ester, all of that is loaded onto Apo B-48. All this is coming from the diet, and this molecule we call it as chylomicron. Now the chylomicron is there in the rough ER, and this chylomicron will be secreted out of the intestine into the lymphatics because they are exocytosed into the lacteals, because the lymphatic capillaries, which are called as lacteals here, they have bigger fenestration. And you know, chylomicron is bigger in size. The maximum size of chylomicron is 1200 nanometer. This is one of the biggest lipoprotein. From my previous lecture I told you. So since it has a bigger size, it cannot go into portal capillaries, so it is preferring to go into lymphatic capillaries. So it enters into the lymphatics. From there it will reach to thoracic duct and then to the right part of the heart, and then from there it is pumped into the left side and then going to systemic circulation. That's how chylomicrons will enter into systemic circulation by being synthesized in the intestine. Okay, so these are some of the points that you should remember with synthesis of chylomicrons in the intestine. And in this I have explained you mRNA editing concept, and I have explained you the importance of microsomal triacylglycerol transfer protein, which is the connector between SER and RER, and chylomicrons, since they are big, so they prefer to enter into lymphatics rather than into portal circulation. Okay, so here is the depiction in the form of figure. So let me just briefly go through again. So SCR is shown. So SCR, we have lipids there after esterification. RER, we have a protein, apolipoprotein B-48. Both are connected with MTP, and you have your lipid chylomicron there in the Golgi complex, and the chylomicrons are exocytosed into the lymphatic vessels leading into thoracic duct. Okay, and that's the reason for that is these lymphatic lacteals, they have higher fenestration. Now let's see what is the metabolism of chylomicron once it enters into a systemic circulation. From the lymphatics, chylomicron enters into systemic circulation. So how it is metabolized? Now, in order to understand the metabolism, you need to know how a chylomicron is activated in the circulation, how it undergoes metabolism within the blood vessel. Now, dietary triacylglycerols, which are digested and absorbed, entering into the enterocytes, and in the enterocytes, especially in the smooth ER, where esterification is going on, and triglycerides, cholesterol ester, phospholipids, vitamin A, D, K, all of them are there in the SCR. Protein, the Apo B-48 is synthesized in the rough ER. Connection is going on with the MTP. Things are loaded onto Apo B-48 and made a chylomicron, entering into lymphatics, find its way into systemic circulation. Now a newly synthesized chylomicron is there in the systemic circulation. We refer that molecule as chylomicron remnant. And now this chylomicron remnant, mainly it has Apo B-48 and triglyceride rich. It has some amount of cholesterol ester, vitamin A, D, E, K. Now this chylomicron in the circulation has to be matured, and the maturation of chylomicron happens within the circulation. For that matter, metabolism of chylomicron, that is conversion of chylomicron into chylomicron remnant, happens within the blood vessel, lumen of the blood vessel. Okay, so what happens here? Nascent chylomicron, called the newly synthesized chylomicron, is going to be matured upon uptake of Apo C and Apo E, especially Apo C-II, Apo C-II and Apo E from HDL. HDL is the one that will donate Apo C-II and Apo E to chylomicron, and that's when chylomicron is matured. Okay, once the chylomicron is matured, since it has got Apo C-II, although it is written as Apo C here, but it is specifically Apo C-II. Now the Apo C-II, it acts as a ligand with the lipoprotein lipase enzyme, and this lipoprotein lipase enzyme, it is attached to the endothelium of the extrahepatic tissue capillaries. You know, extrahepatic tissue lined by the capillary for all the nutrients that has to come in. So the capillary of the extrahepatic tissues, so they are lined by an enzyme called, means endothelium. Over the endothelium, one of the enzyme that is expressed is lipoprotein lipase enzyme. It is there in the name, lipoprotein lipase. What lipases do in general? Lipases, they are going to degrade triacylglycerol, degradation of triacylglycerol. That's the substrate for any lipase that you see. So lipoprotein lipase is going to degrade a triacylglycerol present in the lipoprotein, and you know triacylglycerol rich lipoproteins, we have two of them. One is chylomicron and other is VLDL, right? So lipoprotein lipase is going to degrade a triacylglycerol present in the chylomicron in this particular metabolic pathway that I am explaining right now. Now this lipoprotein lipase, it has got a tissue specific expression. What is tissue specific expression of lipoprotein lipase? Lipoprotein lipase that is attached, that is expressed over heart, like endothelial capillaries of the heart. That lipoprotein lipase, LPL, heart LPL, I'll write it like this, heart LPL as low Km for triacylglycerol, whereas adipose tissue LPL has got high Km for triacylglycerol. So that means heart LPL has got higher affinity for triacylglycerol compared to adipose tissue lipoprotein lipase having lower affinity. Why? Because the major source of energy for the heart is fatty acid, which will come from degradation of triacylglycerol. Heart is entirely dependent there, predominantly I would say, for energy coming from fatty acid oxidation, and that come from degradation of triacylglycerol. That's why preferentially heart will use chylomicron and VLDL triacylglycerol at all conditions. Only when VLDL and chylomicron levels are high in the blood, at that time adipose tissue lipoprotein lipase is active, and that's going to take triacylglycerol, degraded triacylglycerol, and take in fatty acids for the storage purpose. Okay, and that's what you need to remember here in terms of tissue specific expression of lipoprotein lipase. Anyway, now with the activation of lipoprotein lipase done by Apo C-II. Apo C-II is an activator of lipoprotein lipase. So lipoprotein lipase is active, and what it does, it is going to degrade a triacylglycerol present in the chylomicron into free fatty acid, and that free fatty acid enters into the tissue which is beneath the capillary there. Okay. So, and what happens to the glycerol? Glycerol will go back to the liver, because when triacylglycerol breaks, means undergoes degradation, it is a sequential removal of fatty acid. Because triacylglycerol has 3 fatty acid, 1 fatty acid removed, and after that another fatty acid, and the third fatty acid. Like sequentially fatty acids are removed by lipoprotein lipase, and those fatty acids are taken up by the tissue which is beneath it for whatever the energy needs or the tissue needs of that particular tissue. If it is a heart, it's going to use it for energy. If it is adipose tissue, it's going to use that fatty acid, re-esterify that fatty acid as triacylglycerol, store it as adipose tissue there, fat in the adipose tissue. Like that, whatever the use of that fatty acid for that particular tissue. So what happens to the glycerol? Coming from triacylglycerol breakdown, glycerol will go to the liver, and in the liver, depending on the condition in the liver, glycerol can be converted to glycerol 3-phosphate to form triacylglycerol, or glycerol can be converted into glycerol 3-phosphate and then into glyceraldehyde 3-phosphate or dihydroxyacetone phosphate, and that can go into glycolysis. That is what happens to the chylomicron in the circulation, done by lipoprotein lipase. And also remember, a hormone insulin is going to induce a lipoprotein lipase enzyme. Means whenever person is in well-fed condition for a long period of time, so insulin is going to increase the expression of lipoprotein lipase over endothelium, especially over endothelium of adipose tissue, and make this lipoprotein lipase to take that extra fatty acids and store it as white depot fat. Okay, remember that point. So the role of insulin on lipoprotein lipase. So overall, chylomicrons are used by the extrahepatic tissues, mainly a heart, mainly used by adipose tissue, skeletal muscle, and other tissues. Now, as the action of lipoprotein lipase is going on over chylomicron, so you know, as chylomicron is a big molecule, 90% of the chylomicron is a triacylglycerol. So this triacylglycerol is rapidly degraded by lipoprotein lipase. Around 70 to 90% of triacylglycerol is removed by lipoprotein lipase in the circulation as the chylomicron is flowing in the blood from one tissue to another tissue. Action of lipoprotein lipase in each of these tissues, so they will take that degrade the triacylglycerol and take free fatty acid. So as this degradation is going on, the size of chylomicron will be reduced and it will become a smaller size. And this chylomicron, so overall, as the size of the chylomicron is reduced, so when 70 to 90% of the chylomicron triacylglycerol is taken out, so at that time Apo C-II will go back to HDL. Whenever significant amount of lipid is taken out of the chylomicron, so Apo C-II will go back to HDL. Now what is present over the chylomicron is only Apo E. And also when it comes to the lipid content, let me modify the lipid content here. So the lipid content here, it will be more of cholesterol ester and very less triacylglycerol. So it will be cholesterol ester is much more than the triacylglycerol here. Okay, so that is what is a chylomicron remnant. So this molecule which is coming out of the action of lipoprotein lipase, where 70 to 90% of triacylglycerol is degraded. So the remaining molecule is a smaller molecule with more of cholesterol ester and less of triacylglycerol, and that is referred as chylomicron remnant. And also note the type of apolipoproteins present over chylomicron remnant. It is Apo B-48 and Apo E. And more importantly, Apo E is important for chylomicron remnant because these chylomicron remnants need to be taken up by the liver. Liver is going to take this chylomicron remnant. So that is done through LRP receptor and also LDL receptor. Most importantly, most predominantly it is taken up by the LRP receptor. LRP is LDL receptor like protein. LDL receptor like protein 1. Okay, and that is why sometimes it is written as LRP1. And this LRP1 receptor, what it does, it is going to recognize Apo E as the ligand. So Apo E is recognized by this LRP receptor and thinks it is endocytosed. All the content present means entire chylomicron gets in and it is going to offload the content. What is there in the chylomicron remnant? Chylomicron remnant is now it has the remaining cholesterol ester because most of the triacylglycerol is all underwent metabolism taken up by the peripheral tissue, 70 to 90% of it. So only little bit of triacylglycerol is left. So more of cholesterol ester, and along with that there will be phospholipid and also there will be vitamin A, D, E and K in this chylomicron remnant. All of that will be offloaded in the liver. That means the liver will be getting cholesterol ester, phospholipid, vitamin A, D, E and K and some amount of triacylglycerol. All of that will be offloaded into the liver. This is what happens to the chylomicrons in the circulation. So chylomicrons will undergo metabolism in the circulation as it is moving from one organ to another organ in the bloodstream. So the lipoprotein lipase is going to degrade a triacylglycerol into free fatty acid and glycerol molecule. Free fatty acids are taken up by the extrahepatic tissues. Glycerol will go back to the liver. Okay, and like this 70 to 90% of the triacylglycerol present in the chylomicron is degraded by lipoprotein lipase. At that time Apo C-II will go back to HDL, and when Apo C-II will go back to the HDL, so we refer the remaining molecule with only Apo E and Apo B-48 over surface. We call that as chylomicron remnant, and this chylomicron remnant contains more of cholesterol ester, phospholipid, little bit of triacylglycerol along with vitamin A, D, E, K. And now that is taken up by LRP receptor or LDL receptor like protein 1, which will recognize Apo E and things are internalized, endocytosed. That's how a dietary phospholipid, dietary cholesterol ester, dietary vitamin A, D, E, Ks and some amount of dietary triacylglycerol, all of that will be offloaded in the liver. That's how they reach liver. Now your vitamin A, D, K and all that, they are already reached liver now by chylomicron remnant. So one of the so two things that you need to take care here in terms of understanding clinical application of chylomicron metabolism, like some of the abnormalities that can happen with chylomicron metabolism. One is, what if there is a mutation in a gene that is coding for lipoprotein lipase enzyme? What if lipoprotein lipase is not working properly? That will lead to elevation of chylomicrons in the circulation. What is chylomicron? Chylomicron has got 90% triacylglycerol. So there will be elevation of tags in the circulation. So that will give rise to hypertriacylglycerolemia. hypertriacylglycerolemia, excess triacylglycerol in the blood happens when lipoprotein lipase is defective or deficient. That's one thing you need to remember, and we are going to study that as familial lipoprotein lipase deficiency later. Now, other thing that you need to remember is, what if there is a mutation in Apo E, apolipoprotein E mutation, which is necessary for chylomicron remnant to be taken up by the remnant receptor, or LRP receptor is also referred as a remnant receptor. Okay, so what happens if this Apo E is mutated? So it is not recognized by LRP. So because of the mutation in apolipoprotein E, so chylomicron remnants will just stay back in the circulation. So at that time, what will happen? So chylomicron remnants will build up in the blood. So this is called as a remnant disease. So it will lead to what is called as a remnant disease. In the remnant disease, not only chylomicron remnants are accumulated in the blood, there is another remnant that we are going to study in later slides, that is VLDL conversion into IDL. IDL is also a remnant of VLDL, and the uptake of IDL by the liver, the mechanism is same what I am explaining for chylomicron remnant. So IDL will also build up. So chylomicron remnant, IDL, both are remnants. Like chylomicron remnant is a remnant of chylomicron, IDL is a remnant of VLDL. So both will build up because of defect in Apo E. That type of disease we call it as a remnant disease. By just looking at the presence of chylomicron remnants and IDLs in the circulation, we can diagnose remnant disease there. Anyway, so these are the two things that you need to remember in terms of clinical application. Otherwise, when it comes to the regulation, I already told you the role of insulin on lipoprotein lipase. Insulin is going to induce lipoprotein lipase, and lipoprotein lipase, it can be tissue specific. Example, heart type lipoprotein lipase has low Km, whereas adipose tissue lipoprotein lipase has high Km for triacylglycerol. Now all the points that I have explained in the previous slide is written here. This is just a quick recap for you. Nascent chylomicron converted into chylomicron in the circulation upon gaining Apo C-II and Apo E from HDL. So HDL is the donor of Apo C-II and Apo E. I have written that here. Lipoprotein lipase is attached to the endothelium of the capillaries, and also note that lipoprotein lipase is attached to the endothelium using a glycosaminoglycan called heparan sulfate. Make sure you remember this also. I forgot to explain this in the previous slide. Heparan sulfate. Heparan sulfate is a type of glycosaminoglycan. So heparan sulfate expressed over the membrane, it is the one that is attaching lipoprotein lipase to the endothelium, and this lipoprotein lipase, it is going to make a connection with Apo C-II present over chylomicron, and in fact Apo C-II, it is an activator of lipoprotein lipase. Now the lipoprotein lipase, that is LPL, is going to degrade triacylglycerols into free fatty acids and a glycerol, and this is how a chylomicron size is going to decrease from 1200 nanometer all the way to 30 to 80 nanometer, which is the size of chylomicron remnant. So the big chylomicron is going to shrink into small chylomicron, and that is because continuously triacylglycerol is taken out. Now the lipoprotein lipase, it has a tissue specificity. That means the Km of lipoprotein lipase can vary. Heart type lipoprotein lipase has low Km, and adipose tissue lipoprotein lipase has high Km. Now the chylomicron remnants are taken up by the liver, where Apo E is the ligand for binding to LRP1 receptor, that is sometimes referred as remnant receptor. So these are some of the high yield points that you must remember. And one more point that I didn't write here, I forgot to do that, is role of insulin. Insulin is going to induce the expression of LPL over endothelial cells. So insulin induces lipoprotein lipase expression over endothelial cells, thereby it enhances the conversion of chylomicron into chylomicron remnant, so that fatty acids are getting into the tissues. So these are the points that you must remember related with metabolism of chylomicron. Now let's move on to metabolism of VLDL. Just now we have seen a metabolism of chylomicron. So metabolism of VLDL is very similar to metabolism of chylomicron. VLDL, it is synthesized in the liver. To synthesize VLDL, there is a need of Apo B-100 synthesis, and this Apo B-100 synthesis is done using Apo B-100 gene, which is coding for Apo B-100 mRNA, and that Apo B-100 mRNA is coding for Apo B-100 protein, and this Apo B-100 protein is the one that is made in the liver and it is used in the synthesis of VLDL. Now, since lipids are synthesized and synthesized in the cytoplasm, like fatty acid is synthesized in the cytoplasm of the liver whenever person has taken high carbohydrate diet, these fatty acids are esterified to glycerol 3-phosphate to make triacylglycerol in the smooth endoplasmic reticulum. Similarly, cholesterol is esterified to cholesterol ester in the smooth ER. Lysophospholipid is esterified in the smooth ER. So in the smooth endoplasmic reticulum, all these fatty acids are esterified, and Apo B100 protein is there in the rough endoplasmic reticulum. So now lipid in the smooth endoplasmic reticulum need to be transported to a protein present in the rough endoplasmic reticulum, and for that we need microsomal triacylglycerol transfer protein, just like what we have seen in the chylomicron synthesis. Now the tag-rich VLDL, which is there in the rough endoplasmic reticulum, passing on to Golgi complex. From the Golgi complex, it will be secreted into the sinusoids of the liver, into the space of Desai, and from there it will just go into the systemic circulation. So tag-rich VLDL is released into systemic circulation. So here is the pictorial representation of how VLDL is made in the liver. So it is coming from the rough ER where Apo B100 is there. In the smooth ER we have lipids. So the lipids from smooth ER will be transported to a protein in the rough ER, making VLDL. VLDL is secreted into the space of Desai, and from there it will be entering into systemic circulation. This is how a secretion of VLDL will happen in the liver. Remember that liver is the one that synthesizes VLDL. Now what happens to the VLDL in the circulation? Now the metabolism of VLDL, it happens within the blood vessel, just like what we have seen with the chylomicron metabolism. Now the nascent VLDL that is coming out of liver, so it has to gain Apo C-II and Apo E from HDL, similar to what we have seen with chylomicron metabolism. Once VLDL gains Apo C-II and Apo E from HDL, so the VLDL is matured here. Now we have Apo C-II present over VLDL molecule, and this Apo C-II, as the VLDL is moving on, it is going to make a connection with lipoprotein lipase, which is attached to the endothelium of blood vessels, and with the help of heparan sulfate it is attached to the membrane, and this lipoprotein lipase, which is activated by Apo C-II, is going to degrade a triacylglycerol present in VLDL into free fatty acids and glycerol. Same story what I have said in the previous topic, that is chylomicron metabolism. So lipoprotein lipase, its tissue specific expression, insulin induction, all those points you need to bring it here. VLDL, as more and more triacylglycerol is degraded, at some point in time Apo C-II will go back to HDL. So whenever Apo C-II will go back to the HDL, at that time we refer the remaining molecule as IDL. So the IDL is the remnant of VLDL. That's what I have written here in the bracket. IDL is the VLDL remnant, and IDL do not have Apo C-II. IDL just have Apo B100 and Apo E. Now ideal also has got some amount of triacylglycerol, not like VLDL, but it has some amount of triacylglycerol. Along with that, it has cholesterol ester, and vitamin E and vitamin K. All this is there in ideal molecule. Now ideal, it can totally be taken back by the liver by binding to Apo E recognizing receptor called LRP receptor. So that's one fate of ideal. Ideal can simply go back to liver. Okay. And then other fate of ideal is ideal can be converted into LDL. We are going to see that subsequently later in ideal and LDL metabolism. Right now, let's restrict ourselves with metabolism of VLDL only. Now, what I have explained here is VLDL, when lipoprotein lipase is acting on VLDL, it is degrading most of its triacylglycerol, and when Apo C-II will go back to the HDL, so the molecule that comes out of it is referred as ideal, which is intermediate density lipoprotein, and also it is referred as VLDL remnant. This is how VLDL is metabolized into ideal. Okay, so ideal has a different fate, including formation of LDL, and LDL is taken up by the liver and extrahepatic tissue as it is shown in the figure here, and we are going to see that in subsequent slides. So let's stop at metabolism of VLDL there, and one of the enzyme that is converting VLDL into ideal, remember it is lipoprotein lipase. Similarly, enzyme that is converting chylomicron into chylomicron remnant is lipoprotein lipase. Remember that. What happens with the lipoprotein lipase? These triacylglycerol rich molecules are losing triacylglycerol significantly and converting themselves into their remnant forms. And the remnant form is taken up by remnant receptors which are there in the liver, and the remnant receptor is LRP1 receptor, which are recognizing Apo E, which is present over remnants, that is chylomicron remnants, and VLDL remnant. VLDL remnant is ideal, and that's what happens there. Now, some of the points that I have explained in the previous slide is written as a recap here, as a review points. So, compared to chylomicrons, VLDLs can be synthesized in the liver both under fed condition and fasting condition. Remember that. So, chylomicrons are synthesized only under fed condition, whereas VLDL is synthesized both under fed and fasting state in the liver. Make sure you remember this point, it's very important. That is the one point that can differentiate between chylomicrons and VLDLs. Chylomicrons are synthesized only under fed condition, VLDL synthesized both in fed state and fasting state. Now, nascent VLDLs are matured in the circulation into mature VLDL molecules upon uptake of Apo C-II and Apo E from HDL. That's an important point. Now, Apo C-II, it activates lipoprotein lipase enzyme, and once lipoprotein lipase is activated, this lipoprotein lipase is going to degrade triacylglycerol present in VLDL significantly. Now, lipoprotein lipase is attached to the endothelium of the tissue capillaries, especially with the help of heparan sulfate. And remember, lipoprotein lipase is induced by insulin. And also we have a tissue-specific lipoprotein lipases. Adipose tissue lipoprotein lipase has higher Km, having a lower affinity, whereas heart type lipoprotein lipase has a lower Km, having higher affinity. Okay, and also one point that I missed in the previous slide is VLDL, it will interact with HDL with the enzyme CETP. What is CETP? CETP is cholesterol ester transfer protein. Cholesterol ester transfer protein, that is what is CETP. And what this CETP does? CETP, as it is shown in the figure here, it is going to get cholesterol ester from HDL and put it on to VLDL, and in return it is going to take triglycerides from VLDL and put it onto HDL. That kind of exchange, it will be done by CETP between HDL and VLDL. So overall what happens as continued action of CETP, what it does, it is slowly removing triacylglycerol from VLDL and loading cholesterol ester into this. So as VLDL is getting converted into IDL, this triglyceride is continuously taken out by lipoprotein lipase and cholesterol ester transport protein, and also it is becoming rich in cholesterol ester because CETP is just pumping cholesterol ester into VLDL molecule. So with that, loss of triacylglycerols from VLDL by the action of lipoprotein lipase and cholesterol ester transport protein. So the gain of cholesterol ester from CETP reaction, loss of Apo C-II to HDL will convert, all these things will convert VLDL into IDL molecule. So in the conversion of VLDL into IDL, so there are certain things going on here. What all the factors that will convert VLDL into IDL? One is action of LPL, lipoprotein lipase. Second is action of CETP, cholesterol ester transport protein, and also a release of Apo C-II later. All that will convert VLDL into IDL molecule. Remember that. And some of the circulating IDLs are taken up by the liver by Apo E receptor, that is LRP1 receptor, or Apo B-100 receptor. There is also an enzyme called hepatic lipase enzyme which is attached over the hepatocyte membrane. Whenever IDL is going nearer to this hepatic lipase over hepatocyte, so this hepatic lipase has a dual role in the liver. One is it acts as a ligand to facilitate uptake of remnants. Now the hepatic lipase which is present over the hepatocyte membrane, it has got a dual role in the liver, because hepatic lipase, it can act as a ligand to facilitate uptake of remnant receptor through LRP1, and also hepatic lipase is going to degrade a triacylglycerol and phospholipid that is present in the remnants, that is IDL and also chylomicron remnant there. So overall hepatic lipase degrades triacylglycerol present in IDLs, and eventually IDLs will release Apo E which will go back to HDL, and that's how IDL can also become LDL. So overall, what happens with the VLDL here? Let me write it down. So VLDL, it is acted by lipoprotein lipase enzyme as I have shown here, as I have written here, right? And it is also acted by CETP, cholesterol ester transport protein, and it is losing a significant amount of triacylglycerol, and then at that time Apo C-II will go back to HDL, and that's when IDL is made. And now this IDL, it is acted on by hepatic lipase enzyme. Hepatic lipase, just now I explained. Hepatic lipase is present over the hepatocyte, and hepatic lipase, what it does, it is going to degrade triacylglycerol into free fatty acid and glycerol molecule. So basically triglyceride, little more triglyceride is taken up. At that time, at some point in time, Apo E will go back to HDL, just like how Apo C-II was going back to HDL, and that's when IDL will be converted to LDL. Okay, so the conversion of IDL to LDL is helped by the action of hepatic lipase enzyme. Now the LDL undergoes CETP catalyzed reaction, exchanging triacylglycerol for cholesterol ester with HDL, thus becoming rich in cholesterol ester. So when IDL is converted to LDL, let's continue that. So VLDL is converted to IDL, and that is with the help of, one more time I am going to write that, with the help of LPL, with the help of CETP, and upon release of Apo C-II. So Apo C-II will be released. It will go back to HDL. That's when we refer that molecule as IDL. Now the IDL furthermore, so it will be converted to LDL, IDL conversion into LDL, and that is done by hepatic lipase enzyme. HL is hepatic lipase. So during this process what happens? There will be loss of triacylglycerol. Basically triacylglycerol is degraded. I'll write it as like triacylglycerol going out as free fatty acid. Here also ideal is losing triacylglycerol tag going out as free fatty acid. Okay, so it is losing triacylglycerol and LDL is made. And note that this VLDL, ideal LDLs, all of them, they all interact with HDL. HDL, which is rich in cholesterol ester. So what it does, it is going to exchange its cholesterol ester for triacylglycerol with VLDL. So VLDL is going to give tags to HDL. In return, HDL is going to give cholesterol ester to VLDL. This is done by CETP. And similarly, HDL is going to give cholesterol ester to IDL, and IDL is going to give triacylglycerol to HDL. That is done by CETP again. So HDL is going to give cholesterol ester to LDL, and LDL in return is going to give triacylglycerol. Whatever triacylglycerol that is still present in the LDL is given to HDL. So overall, HDL is going to exchange its cholesterol ester for triacylglycerol with VLDL, IDL and LDL molecules, all three of them. Okay, and that is done by CETP. So because of this, what will happen eventually? So eventually VLDL is becoming rich in cholesterol ester as it is going towards IDL, because it is losing triglyceride and gaining cholesterol ester from HDL. IDL is again losing triacylglycerol and gaining cholesterol ester as it is going towards the LDL formation, and LDL is again gaining cholesterol ester by interacting with HDL and losing triacylglycerol. So by the time LDL is made, LDL is super rich in cholesterol ester. That's why 50% of the LDL, 50% of the lipid in LDL is cholesterol ester. So all these reactions, they will help in the formation of LDL molecules. So VLDL undergoing metabolism with the help of lipoprotein lipase and cholesterol ester transfer protein to become IDL. IDL is undergoing a metabolism catalyzed by hepatic lipase and CETP to become LDL, and LDL further undergoes metabolism with the help of CETP to gain more and more cholesterol ester, and LDL becomes rich in cholesterol ester. Now this LDL, 30% of the circulating LDLs either taken up by the extrahepatic tissues, and while 70% of the circulating LDLs are taken up by hepatocytes using LDL receptors. And the uptake of LDL is mediated by Apo B-100 as the ligand. So LDL binds to Apo B-100 receptor, and some of them can also bind to Apo E receptor, but mainly LDL is taken up by the tissues with the LDL receptor, which will recognize Apo B-100 as the ligand. Okay, and that is how overall VLDL is metabolized into IDL, and IDL is metabolized into LDL, and LDL is taken up by the extrahepatic tissues and also hepatic tissue. 30% is taken up by the extrahepatic tissue, 30 to 40% in fact, and 60 to 70% is taken up by the hepatic tissues. Now let's move on to see a disorder that is associated with chylomicrons and VLDL metabolism, and that is A-beta lipoproteinemia. So what is the meaning of A-beta lipoproteinemia and what are the characteristics of A-beta lipoproteinemia? A-beta lipoproteinemia is because of loss of function mutation in a gene that is coding for microsomal transfer protein or microsomal triacylglycerol transfer protein. So in this condition, because MTP is the connection between, as we already know, the role of MTP is it is connecting SCR to RER. Okay, so SCR is the one that has got lipids are there in SCR, and Apo B-48 and Apo B-100, both in the intestine and in the liver. In the intestine we have Apo B-48 and in the liver we have Apo B-100. Okay, so these are the Apo B-48, B-100 present in the rough endoplasmic reticulum. Lipids in the intestine and in the liver while we are making chylomicrons and VLDL. So for chylomicron it is intestine, for VLDL it is liver, same mechanism. So lipids in the SCR, protein in the RER. So lipid from SCR has to reach a protein present in the RER, and that is mediated by MTP, microsomal triacylglycerol transfer protein. Okay, so if there is a mutation in a gene coding for MTP, that is loss of function mutation, so that leads to decrease in the transfer of lipids from smooth ER to a protein that is present in the rough ER. Because of this, what will happen? So there will be decrease in chylomicron formation. Chylomicrons are decreased, and decrease in VLDL formation. Both chylomicron and VLDLs will be decreased, and because of this, so Apo B-48 and Apo B-100, they are degraded. They will be degraded because chylomicrons are not formed, VLDLs are not formed, or rather decreased. Okay, so inability of these patients to secrete Apo B containing lipoproteins, that will lead to undetectable plasma levels of Apo B's, that is B-48 and B-100, because they are degraded. So chylomicrons and VLDLs, LDLs, markedly deficient in vitamin E, mild to moderate deficient in vitamin A and vitamin K is seen in this particular disease. Why? Because chylomicrons not seen, VLDL very less. So chylomicron decreased, VLDL decreased. When VLDL decreased means IDL and LDLs are decreased. And since chylomicrons carry vitamin A, D, E, K from intestine to the liver, and then the VLDLs carry vitamin E from liver to the peripheral tissue. So because of this, when both chylomicrons and VLDLs are affected here, so one of the most deficient fat soluble vitamin in A beta lipoproteinemia is vitamin E. There will be severe deficiency of vitamin E, and mild to moderate deficiency of vitamin A and vitamin K can be seen in this particular disease. Vitamin D deficiency may not be seen because vitamin D is synthesized in the skin. Okay, now patients with A beta lipoproteinemia, so they will manifest with the signs and symptoms in the early childhood with diarrhea and failure to thrive. And the majority of the signs and symptoms of A beta lipoproteinemia that we see in this disorder is because of the fat malabsorption in the intestine, fat malabsorption, and most importantly decrease in fat soluble vitamins, and most importantly in that is decrease in severe deficiency of vitamin E. And note that vitamin E, it has got a antioxidant function, and it is going to protect our cell membrane. So because of this, so that some of the signs and symptoms that you see here in A beta lipoproteinemia is spinocerebellar degeneration, because spinal column, all the long myelinated neurons, so their membrane need to be protected by having sufficient vitamin E antioxidant there. So there will be degeneration of myelinated axons, and that will give rise to spinocerebellar degeneration. And the spinocerebellar degeneration will give rise to the peripheral neuropathy signs, which includes altered sensation to the touch, temperature, pressure, vibration sense, ataxia, all these, and weakness in the muscles, all these signs can be seen there. Progressive pigmented retinopathy can be seen, leading to blindness, and acanthocytosis, that is spiky membrane over the red blood cell, eventually giving rise to hemolysis. Okay, so the presence of spinocerebellar degeneration and pigmented retinopathy in A beta lipoproteinemia often can be confused with the diagnosis of Friedreich's ataxia. Remember, Friedreich's ataxia, one of the neurological condition, it is a differential diagnosis for abetalipoproteinemia. Now let's move on to see our another disease which is connected with metabolism of chylomicrons and VLDL, and that is familial lipoprotein lipase deficiency. The familial lipoprotein lipase deficiency can be because of genetic defect leading to deficiency of enzyme lipoprotein lipase or decrease or defective activator of lipoprotein lipase, that is Apo C-II. So LPL deficiency or Apo C-II being defective will lead to decrease in the clearance of chylomicrons and VLDLs from circulation. Because lipoprotein lipase is the one that will metabolize chylomicrons and VLDL, so deficiency of lipoprotein lipase will lead to increased levels of VLDL and chylomicrons. And you know VLDL and chylomicron both are triacylglycerol rich molecules. That means there will be elevation of triacylglycerol under fasting condition, which is invariably more than 1000 to 2000 milligram per deciliter. That is too much elevation of triacylglycerol in the blood, because normally it is around 150 milligram per deciliter. Now fasting plasma, when the plasma is taken, fasting plasma in the test tube, it looks turbidity, otherwise plasma is clear. So here it looks turbid, and also if the plasma is stored in refrigerated at 4 degrees centigrade, there will be creamy supernatant can be seen in the plasma, and this creamy supernatant is because of presence of high levels of chylomicrons, and turbidity is because of VLDL. Remember that creamy supernatant. So creamy layer is because of presence of chylomicrons. You know chylomicrons are least dense molecules, that's why they float on the top, and turbidity is because of VLDL. Make sure you remember that. And also the manifestation of this condition happens in the childhood, where there will be recurrent episodes of abdominal pain, and the severe abdominal pain in the condition is because of acute pancreatitis, because hypertriacylglycerolemia, because of elevation of VLDL and chylomicrons will lead to acute pancreatitis and severe abdominal pain. Now you look at plasma sample here. Normal and abnormal plasma sample is shown. So the normal plasma sample, as you see, it is very clear there, whereas the lipoprotein lipase deficient patient plasma sample, you see a creamy supernatant here, and this creamy supernatant is because of excess chylomicron. And also the turbidity that you are seeing here, because that plasma is not clear when you look down there below the frothy layer there, which is creamy top layer, and that is because of VLDL. Excess VLDL causes turbidity. Excess VLDL causes turbidity, and excess chylomicron will make a creamy supernatant kind of frothy thing that we are seeing here. Here in this sample also, you see that creamy supernatant there. Alright, so that is one of the laboratory feature how we can diagnose a familial lipoprotein lipase deficiency. Now severe hypertriacylglycerolemia, in this condition, so it can cause skin lesions giving rise to eruptive or tuberoeruptive xanthomas. This is the characteristic of lipoprotein lipase deficiency. Eruptive xanthoma means xanthomas these are fatty material accumulated just beneath the skin, smooth in texture. So they just come in eruption, all in collections, and also they are raised over surface, and where you can feel the surface there, like a tuberous or nodular kind. And that type of xanthomas are referred as eruptive or tuberoeruptive xanthomas. Patients will also show corneal arcus, lipemia retinalis, and xanthelasma are the most common ocular abnormalities in familial lipoprotein lipase deficiency. So here is some of the figures to explain tuberoeruptive xanthomas and also the fundus. Like when the ophthalmoscopy, like retinoscopy is done, so you can see the retinal blood vessels kind of having that creamy appearance compared to the normal blood vessels, where you see that clear red blood vessels there in the retina, whereas on the right side you see creamy appearing blood vessels upon retinoscopy, and that is what is called as lipemia retinalis. So that's about metabolism of chylomicrons, metabolism of VLDL. We have seen how chylomicrons are converted to chylomicron remnants, role of lipoprotein lipase, how VLDL is converted to IDL, IDL into LDL, role of lipoprotein lipase, hepatic lipase, cholesterol ester transfer protein. And also we have studied about A beta lipoproteinemia, familial lipoprotein lipase deficiency. That's about chylomicron metabolism and VLDL metabolism. I hope this video has helped you in understanding this very important concept. Thank you.